Thank you very much to the organisers for inviting me to speak. So I'm going to talk just very briefly. It's a bit of a double act. You can choose your own comedy double act that you think we're going to be. Just talking about timely IV to oral switch for antibiotic therapy, which, to save time for everybody, I'm going to call IVOS, and you'll see it abbreviated in my slides as IVOS, so if you're not familiar with that so much. Just to start off with some... where am I pointing that? Oh, okay, so no declarations of interest. There was a big build-up to that slide, so apologies. Right, so just want to give you a flavour of what IV antibiotic therapy looks like in NHS secondary care at the moment. So we know that almost 2/5 of patients in hospital at any one time are on antibiotic therapy. And of that, the greater proportion is intravenous therapy. So when you do the simple arithmetic, we know that about 22% of inpatients, so 1/5 of inpatients, are on IV treatment, IV antibiotic treatment at any one time. And when you count up the number of doses that are being dispensed and supplied from hospital pharmacies in England and work it out, it equates to about 17 million days of antibiotic treatment each year in English hospitals. And we know that of those 17 million days of treatment, there's a large proportion of those which are unnecessarily being given IV, and that equates to about 5 million days of unnecessary IV therapy in any one year in English hospitals. And that's really significant when you think that preparing and administering IV antibiotics is quite a workload burden for nursing staff, and there's been some recently published data, time and motion studies, which shows that it takes about 22 minutes on average to prepare and give an IV dose of antibiotics, and it takes about 80 seconds to give the equivalent oral dose. So there's an enormous potential time saving for our hard-pressed nursing staff if we could just deliver a more timely and appropriate oral switch. Next slide, please. Thank you. So just going to really, in a couple of slides, summarize the benefits to everyone from timely IV to oral switch. So we know that it's associated with a reduced probability of errors. When you think of the sort of the reconstitution and dilution and drug administration steps involved in IV treatments, there's quite a high probability of errors occurring, which aren't necessarily there for oral treatment. So it can improve patient safety. It's also been shown in trials to have a reduced rate of adverse effects, so things like thrombophlebitis from giving that irritant IV treatment, but also lower rates of reported adverse drug reactions. If you remove the need for cannula by removing the IV antibiotic, you can potentially reduce the number of bacteremias, and we know that hospital-associated bacteremias, you get about 1 for each 2,000 days of a patient has a cannula in situ. So by removing the need for cannula, you potentially reduce that bacteremia rate. And we also know the patients much prefer to be on an oral antibiotic than its IV equivalent. We all probably would. Nobody wants a cannula in their arm if they don't need it. Next slide, please. And then there's also wider benefits to sort of workforce, the NHS in general. So we know that if we can switch from intravenous therapy, which is often a broad spectrum agent, to a narrower spectrum oral agent, we can help to meet some of our prescribing targets around reducing broad spectrum consumption, which will have a consequent impact on antimicrobial resistance. As I mentioned, giving IV treatments takes up an enormous amount of nursing time. So if you just switch one drug, that's given 3 times a day, you're saving an hour of nursing time every day potentially. And when you scale that up to the number of hours we're having nurses giving IV treatments, then that's an enormous workforce benefit. We know that it can also reduce length of stay. There's clinical trials that show if you can do an early IV to oral switch when that's appropriate, it reduces length of stay by a day. And again, when you scale it up across the NHS and think of our recovery and restoration program following the pandemic, that's potentially enormous. And we also know that there's a simple cost saving as well. So just in pure drug costs alone, switching from an IV treatment to its equivalent oral option will save about 10% of drug costs, which over the course of a year is about £10 million as a sort of a conservative estimate for the NHS. And the final benefit, next slide, please, is just, again, maybe a little bit esoteric, but actually really important and becoming increasingly important, is that IV antibiotics are associated with quite a high carbon footprint. If you think of all the single-use plastic in that tray in the picture on the bottom left, some work's been done that calculates that, for example, with IV ciprofloxacin, it's about 70 times more carbon than its equivalent oral treatment over the course of a week. So there's potential benefits for the greener NHS agenda as well. So that's another potential driver for IV toral switch. Next slide, please. And so really, who's currently involved in IV oral switch and who could be more involved? While it's clearly often a medical decision to make, and I'll come back to that in a second, we know that the infection specialists are very influential in this, so the microbiologists, ID physicians, the stewardship pharmacists, nurses, and infection control and prevention and control teams as well. Their challenges are that they don't know the patient usually firsthand, but they do have a very high impact when they intervene on patient care. They have a high credibility, but they're spread very, very thin across a large organization, for example. So they really need more time to get involved in IV toral switch, which maybe they don't have. We know that there's some teams that are remote or allied to the wards and the clinical teams. So the pharmacy department itself is probably screening prescriptions every day for IV treatments remotely from the dispensary, and perhaps they could get more involved. Discharge coordinators could potentially be asking questions, who have you got on IV today? Because if you switch them, they might be able to go home tomorrow. So it's just those little opportunities, taking every opportunity to make an impact. Matrons and directors of nursing as well, once they realize the workload impact, which they probably already do, to be fair, but if we can put numbers on it like we have recently done, then that really demonstrates the impact they can encourage their nursing teams. And then sort of even more remote and allied, but if we can set up the infrastructure with IT, for example, with prompts in electronic prescribing systems to ask for an IV toral switch, then potentially we can empower much more of the organization. But really it's the ward-based teams that are probably going to really drive this. So we know that the medical staff will be reviewing patients, pharmacy will be prompting those reviews, but the nursing staff are perhaps an unharnessed team really up to now, but now that we can demonstrate the impact and the positive benefits for them as well as their patients, then hopefully we can empower them, but we just need to give them the tools and resources to get more involved. But the benefit is they're on the wards 24/7. The medical teams are on the wards for long periods each day, and the pharmacy teams for somewhat less, but still, those three teams working together could really have a large impact. Next slide, please. And some stakeholder engagement work that's been done in the East of England was published just last year. So they were trying to explore what the barriers around IV toral switch, what the enablers for that were, and what the challenges that we need to overcome. And obviously barriers are operational in that there's often not enough staff to do this work. And it's kind of a strange paradox in that, we're too busy doing the work to think about how we do the work. So we're too busy chopping down trees to sharpen the axe. Is probably a good analogy. But there's also cultural barriers as well. So some wards, some medical teams or surgical teams are very hierarchical, and people don't feel empowered to challenge if a patient's still on IVs. And we also know that there's quite a large degree of prescribing etiquette. So often doctors don't like to change or challenge the prescribing decisions of other doctors, so they let it slide for a day or two. And that translates into quite a lot of potential unnecessary IV treatment. Enablers, as I've mentioned, might be the better use of IT, so decision support tools built into electronic prescribing systems, alerts and prompts in electronic prescribing systems, having more stewardship staff. We've put pharmacy down here, but actually increasingly stewardship nurses, pharmacy technicians are a useful resource, and having timely access to expert advice. So if somebody does think that their patient could be switched, that they've got somebody they could ask for advice and support. But the challenges, of course, are the patients themselves, their increasing complexity in secondary care, but also different case mixes in different organizations, maybe more or less amenable to IV toral switch. We need to be able to provide education and training so that people feel confident and capable of doing this. And of course, doing all of this in a timely fashion in a pressured system is always a challenge. Next slide, please. So one of the main things that's happened recently to sort of address some of these challenges and overcome them is that the UK HSA, so the UK Health Security Agency, NHS England, and frontline clinicians sort of did a large Delphi consultation process and came up with national criteria for IV toral switch. So this is a very structured approach. It takes a lot of the guesswork or the uncertainty out of trying to decide if a patient is suitable for IV toral switch. Just takes people through a stepwise process where they can assess assess if the patient might well be suitable, and then they can go on to either suggest that switch if they're maybe a nursing staff, non-prescribing staff like nursing and pharmacists, or go ahead and make that switch if they are prescribers. And we think that's going to be really, really important. And with national standards, it has high credibility as well. Next slide, please. And there's supporting resources. This is a draft version of an infographic which UKHSA have been developing. It's just awaiting final comms approval, but we'll be able to use this as screensavers, as posters, and as a prompt. And it just summarizes very visually all the various benefits of IV Toro switch that I've mentioned that people can really relate to. Next slide. And the other question really is the patient, and have we overlooked these? So we know that we've had good success with Clean Your Hands campaigns where we encourage patients and empower patients to say, have you cleaned your hands? It's okay to ask that question. Maybe we need to think about, other aspects of care like IV treatment. Do I still need this IV? I've had my breakfast this morning. How do we get that message across to patients that once they're eating and drinking, they may well no longer need IV treatment? So that's just a consideration. I don't have any solutions around that at the moment, but I think it's an important thing to think about. Next slide. And then just the sort of final slide really is just as just to show how we're sort of trying to drive this improvement. So you'll be probably aware that we now have a sequin target, which is currently running for this financial year around timely IV Toro switch or prompt IV Toro switch. So we're incentivizing trusts to really focus on this issue over this next financial year with hoping to see an improvement in timely switch rates. And to support that, there's a whole suite of resources. Dawn's already mentioned the Future NHS website, and we've got loads of resources around IV Toro switch on there, and we'll continue to add those case studies and good practice examples, infographics. There's a forum for discussion where people can ask questions, and we recently did a sort of a mini conference, about 2.5-hour webinar on IV Toro switch, where we got lots of presentations and practical tips and experience from people in the front line. So that's available, and the link to that is on our Future NHS space as well. Next slide. So I'd just like to finish by thanking Naomi and Sabina, whose slides I shamelessly stole for this presentation, and I should really acknowledge. So thank you very much.
So from my point of view, it was actually, how do we put this? How do we enable our nurses to be able to think about IV to oral switch on the wards, and what resources we can tweak slightly to make it possible for that. So from my point of view, I have no declarations of interest. From a national driver point of view, the UK antimicrobial resistance 5-year plan actually sets out how we tackle AMR. So we need to reduce the need for the antibiotics in the first place, but we also need to optimise the use of those antimicrobials. And a bit later, I'll just explain, how we can do that. And we need to invest in innovation. And what we have underpinning that is actually how these content areas where we're reducing infections and strengthening our stewardship. And improving surveillance. So why is it important for IPC and vascular access? So it's estimated that about 8.9 million healthcare acquired infections are seen annually. And around 30% of those are resistant to antibiotics. So it's a major, major problem for us. We know catheter-related bloodstream infections are one of the most dangerous things that we can see, the bloodstream infections, and that actually a lot of these device-related infections that we do see could be preventable, and we need to be aware that they're preventable. So from an IPC risk point of view, I am very old. I found that out last night when we had the gala dinner, and we were asked at that how long we'd been in the NHS. And you saw people coming down because they went 5, 10, 15, 20, and I'm still stood up. And I think I was one of the last 3. So I've been a nurse for nearly 40 years now. God, that makes me feel old. But when I started and when I went on the wards, it was we never saw, we might have seen 1 or 2 patients with vascular access on a warded environment. Now most of our patients actually have vascular access, and the 3 that haven't are unusual. So it's become a common part of our practice. So from that point of view, it's we need to be aware what we do with vascular access, and I think that really is important. We know that there is evidence, there's a multitude of evidence out there to say the longer that vascular access is in, the more risk of an infection there is for that patient. And I read something I'm a biofilm geek, to be perfectly honest, and I read somewhere that actually that vascular access goes in, we might have done we've gone through all the procedures that we needed to for that. Within about 4 hours, microorganisms are forming biofilms. Okay, so once those biofilms are there, they can seed off and can create infections. So you really have to be aware that these medical devices are a risk for our patients, and we need to get them out as soon as we possibly can. As Connor said, it's patient compliance. What does the patient want? Do they want to be a pincushion? As you can see, this is an elderly lady, and she's obviously had multitude of vascular access. My mother was in hospital last year, and she looked like a pincushion as well. So actually, if we could have got to an oral, change from the IV to the oral as quick as possible, it might have prevented some of this. So I've talked about invasive medical devices, and vascular access is probably the greatest risk of us getting bloodstream infections. But we need to be aware of the sources those infections, microorganisms can enter. So from a practitioner's hand point of view, the patient's skin itself, catheter hubs when we access, the catheter tubing and the giving sets. How many people have actually seen giving sets and they're hung up? Or do we not see that now? And actually the infusate themselves, so the IV fluid that we might be delivering to that patient, that actually can have microorganisms in. And I'm going back to the fact I'm old, is I remember IV medication and the fluids, and I remember holding it up and saying to everyone, no fish. No floating bits in the infusates. And I was like, but do we do that now? Or is it just it's common that we're putting these fluids into patients? And also you've got the contamination of your equipment through indirect contact. So routes of contamination. So we have extraluminal, we have intraluminal. From an extraluminal point of view, it's when you're putting that vascular access in, and what you find then is those catheters placed for a shorter duration when you see the extraluminal infection, so you see it around the site itself. With the intraluminal ones, infection sources emanates from the catheter hub itself, from the catheter tubing, or from your fluids, as we mentioned just before. But those intraluminal sources predominate when we have that vascular access in for long periods of time. And we were talking, you were talking before, Connor was saying, I remember being on a ward and a little old man with PICC lining. Wandered round, doing my ward round, and it was basically, that PICC line was in not because they were using it, but basically because the consultant was on holiday and nobody would let them find out. I've just got a red, so I'm going to go very quickly through these. I do apologise. So they're the vascular complications that we see. And as I say, I'm going to look just basically at vessel health and preservation as a resource tool. So this is the vessel health and preservation, and I'm going to plug at the moment that if you go to the IPS stand, you'll be able to get hold of these posters. And what we did is we looked at how we could change it. We had device necessity, and actually, why have we got that vascular access in the first place? And do we still need it in? And we should be asking that question every single time with that vascular access. So we have an assessment on the vessel health and preservation, and what it is to go through, actually, why have we got it in? Is there any problems? Is there anything that we can change? And is it actually necessary? So what we've done with this, and I'm hoping the pointer is going to work, is this pointer, and I do apologise that it hasn't come out very, very well on here, but you will see it on the posters, is we've changed the wording so that actually it says now, does the patient need this IV device? Consider, can the antibiotic or other medication now switch to oral or alternative routes? So it's a prompt for our nurses when they're using this. And what we're going to do as we go forward is we're actually going to look at other resources that we have for vascular access. And we are going to start to change it and tweak it so that we give our nurses those prompts when you're at the front line and when you're dealing with your patient. So my acknowledgements is obviously for Carol Hallam and the Vessel Health and Preservation team, and also to Andrew Barton, who worked on us when we looked at the VHP and how we were going to change the wordage, and NIVAS for their help with this.